Florida was Wyoming is much nicer. Yeah, because I've been in Florida for a week,
This is the start of the OMMP Cannabis Commission.
I know I can.
It's not. She's like, it's too far from the ocean.
They're still twiddling their thumbs.
Okay, good afternoon. I'd like to call this meeting to order. So we're going to derail. Good afternoon. Why don't we just start by going around the table and everybody introduce themselves. We're all pretty stable entities, but Cedar Gray is a new member, so I'll have him just give a short bio and a little bit more of an introduction since we're welcoming him to the committee. So why don't we start? Anyway, start. Katrina, you want to start?
Sure.
Sorry. Katrina Hedberg, State Health Officer with the Public Health Division of the Oregon Health Authority.
Andre Uso, I'm the OHA representative, administrator for Center for Health Protection, so all the public health regulatory programs.
Jesse Sweet, I'm the agency representative from the Oregon Liquor Control Commission.
Cedar Gray, this is my first meeting. Brief bio, I'm a 6th generation Oregonian. I've been a patient grower and caregiver since 2000. One of the founding members and founding president of the Oregon Sun-Grown Growers Guild, and CEO and co-founder with my wife of Siskiyou Sun-Grown OLCC company. Yeah.
Rachel Knox, co-founder with my family of American Cannabinoid Clinics and also co-chair of the commission.
I'm Esther Chu. I'm an associate professor of emergency medicine and research faculty at Oregon Health and Science University, and I'm the current chair of the Cannabis Commission.
Anthony Taylor, president and co-founder of Compassion Oregon, a medical cannabis patient advocacy organization.
Jeff Coons, my full-time job is with the Kaiser Police Department, and I am the law enforcement representative for the commission. And welcome, Cedar. We work together on other committees, so good to see you here.
I'm Carol Gann, the section manager for the program, and we are administrative support to this group.
Margaret Blushinger, I'm with the Medical Marijuana Program Policy Analyst, and I'm also support for the Commission.
And I'm Ramon Caballon Vasquez, economist with OMMP.
And I think someone just joined us on the phone. Would you like to introduce yourself?
Some could be listening.
Oh, okay. All right, so maybe it's just somebody listening. I would like to also move to approve the minutes from the May 21st meeting.
I'll make a motion that we approve the minutes.
I realize they are of biblical proportions. So if you want a moment to look through. Right, but the length of it is because we had our 4 subcommittee reports. I think we've all got pretty familiar with those, but you may want to look over your own subcommittee report just to make sure that it was captured accurately. Still moving forward? Oh, yes, okay. All right, I'll turn it over to Carolyn for a few announcements.
Thank you. First is just a friendly reminder that this building, the PSL B building and the sites around it are a smoke-free and vape-free area. We've been asked to remind all groups that we cannot smoke nor vape, and that does include marijuana. That is part of the Indoor Clean Air Act. So just a reminder. The other part on my part of the agenda, and I will try to go through our components quicker so that you'll have more time for the substance. On the assessment, so on July 12th, we emailed the assessment and cover letter to Dr. Chu and then to the rest of the commission. This assessment was requested by our OHA director, Patrick Allen, to kind of have us look at our program, look at the areas that we felt needed improvement, and to put that report together. He felt it was important to be transparent and thought that the contents of the assessment would help your commission work as you're looking at oversight and the program as a whole. If you have questions, I can answer questions, or if you've had time to review. We felt it's a good starting point for you to work from. That's all I have on that. Any questions?
Is that in our packets?
Yes. It's should be in the, I think, where do you put them?
It's right behind
It's
it.
in the packet.
The first name.
Yeah. I saw it there somewhere, I'm not quite sure which part.
So Jeff Coons, for the record, I have some questions. I'm not completed with the review of it, and I don't know if this is the appropriate time and place to discuss the questions that I have, but I'll throw a couple out. And there were a couple things that stood out. First, I want to thank the director for asking that the report be completed. I want to applaud them for doing that. There's some concerns with the report, obviously, that were pointed out, and problems that need to be addressed, and hopefully the commission will review the report and make appropriate recommendations to the legislature this upcoming session. But one thing that really stood out to me was the lack of grow site inspections, and the fact that in the literature it spoke of approximately 25 hours of personnel time, maybe involving 1 to 5 employees to do one inspection, and a 70 question or 70-step procedure. I'm wondering if the commission could receive a copy of the 70-step procedure so some of us can look at it and just see how detailed these inspections are, or can things be streamlined in that area so we're not spending 25 hours to do one simple inspection. And I'm also wondering, of the 58 inspections that were done, there was no information included in the report about what did you find. Are you finding that people are in compliance? Are you finding a host of problems and you're trying to train and educate the growers? Or that part was just kind of left out for me as to what you're finding out there. So, but I really appreciated the report.
I can get that information, so we'll send you the actual inspection that the team uses. I think when they were referring to that, it's more of like the entire process. You know, the inspection, but there's follow-up, and there's, you know, depending on the situation, and it hits different people. But yes, definitely, we'll look at that. And I'll have them look at the analysis of the inspections.
Is there any other feedback on the assessment, or do you want to take a moment now to read through and respond? That might be worth it because we meet so rarely, and it seems like therapy. Sorry, go ahead.
Yeah, so I think it might be helpful, rather than having everybody read through, is it possible either for Carol or Andre or Raymond to kind of just do very, 5-minute high level, as opposed to having us all read through it, sort of what the big points were and what the big challenges are. Again, I'm trying to figure out how to, what the Cliff Note version is, or what their 5 talking points are, or something like that.
Yeah, I think that makes sense, and I think it just might trigger things that should be addressed within the reports themselves as we go from subcommittee to subcommittees. I think worth at least a mini thing, and all of us should go through it in more detail later.
I can do that. So we were asked to look at the challenges of the program, and this did come, you know, I have heard feedback that it wasn't patient-centric enough. That wasn't the ask, so you have to understand what the ask was of us to write this report. So we were asked to look at the challenges we had and to kind of line them out, look at what we did well, or what we assumed we did well, and look what we're doing to try to mitigate those areas. So we highlighted number 1 is our tracking and reporting. We know that that is an area that needs improvement. So we did highlight that. We have a monthly tracking system, which is not a seed-to-sale system, so it makes it very difficult to come with quantifiable data. There's a confusion with people, which we tried with communication out as to types of units they should use. So there's some of the data that comes through is difficult to use due to the way that they're reporting it. We also find that after a harvest has happened, that our compliance goes down. So we still require a monthly reporting even if you have no inventory. And so we've sent out bulletins and information to inform them that you must do that even if you are not. So we know that that compliance rate goes down at that time. The other area that we were looking at was we had issues with our grow site, validating the grow sites on the actual addresses, and we were alerted to addresses being submitted to the program that were not real addresses. People were adding suites or B or 1, 2, 3 or different items where it is actually still the same grow site. It's the same property, and in essence we're subdividing property that is not legally subdivided. So we realized that was happening and then have taken appropriate measures through statutory rule change to address that, so that if we do get those types of situations, we will contact the applicant and ask them to provide us proof of that actual address. We also highlighted issues we had with our processor and dispensary applications. We started our program, the compliance program started in 2015, at the end of 2015, and at that time, early retail sales had already started. People were trying to, I think, maybe get their place, their spot, their property set up, their application in place before OLCC was going to begin registering them. So we had a huge influx of applications. So we went up to 423 actual applications coming in. At the same time, we had processor applications that were coming through, and it was the same staff that were trying to process those two things. So we had issues in that area. And again, it kind of flows into the resources not meeting the demands. We didn't have enough staff to be able to address that. Part of the issue that we had was businesses were also beginning to transition to OLCC. So we were trying to be very prudent in not hiring staff when we didn't really know what was going to be happening in the future. So it was kind of a really hard catch-22 situation in that area. The grow site inspections, grow sites, the legislation for grow sites did not come until 2015. So grow site inspections is new. The responsibility for doing them is new. There was nothing developed. It had to be developed. And it is comprehensive. They didn't just write out, these are the steps to follow. They brought in OSHA, they brought in risk management. This was a pretty new territory. In 2016, they went out and they conducted 16 grow site inspections. They used those as a basis to try to develop the actual process. Then they went out in 2017 and completed the inspections. The process started in August of 2017, and in that time frame through the end of the year, they completed 58. One highlight I would want to mention is that in the media and such, you'll hear that there are 20,000 grow sites. We do have 20,000 grow sites, or we did at that time, but not all grow sites required an inspection. So I do want to bring those numbers down a little bit to more reality, and yes, that is a low number, but the majority of our grow sites are patients that are growing for themselves, so they are not inspected. So I pulled the report just as of today. I don't want to go back and try to mish numbers, but currently we have 19,045 grow sites. Of those, 5,127 need to report. So, yes, there is still a lot of room for improvement, but it wasn't quite that was portrayed in the media. So, that's important to know. We also, we've had a lot of changes. Our program had 9 legislative changes that have had some kind of an impact on what we were doing in 2 years' time. Every one of those changes has required us to modify existing systems. The way that the legislation is written, it's not written to the way that our systems are set up, or even how we do our work. So we're having to try to put a round peg in a square hole at all times, and we have existing systems, and then we have to keep trying to modify them to meet the legislative need and try to get that done in the time frame that is stated. And we've actually done a very good job on meeting those deadlines and getting the systems changed. But sometimes I said it's like you're building the plane, and then somebody says turn it this way, and then you turn it. So we've never had a time where we actually have had anything settle. So, if you want to really look at your work and you want to analyze it and you want to see where you have your improvements, usually you get to a point where something settles before it changes again. We haven't had that. So well, even more than one session, but so nothing ever gives you a stopping point. So that's a challenge that we've had. I think we have done a much better job with our outreach to our participants. I'm not going to say that the history was great, but I do know in the last 2.5 years, we've worked really hard to make sure we are communicating with our population as much as we possibly can. When we implemented something that's a change, we go out and we do outreach sessions. We did that when we implemented the grower reporting, when we implemented the patient online system, when we had to implement the seed-to-cell tracking for people. We have gone out and we've really tried to think of, in many ways as we possibly can, how to communicate this information to the population. I have told others I'm open to suggestions on this completely, because if we're not reaching people, then we need to figure out another way to do it. So those are kind of the high level areas, I would say, kind of trying to put out, we know we have areas that we need to improve. We've already put some things in place as far as steps to address. Some of it has been statutory changes that we're mandated to do now regarding the reporting and compliance. If a grow site is required to use the CTS system, or if they're required to use OMOS and they're not, we are moving to non-renewal revocation. So we are taking compliance efforts. Even in that, it's difficult. Having, and that's one reason why I think we took the educational approach historically with that, is that it's a lot of time and effort to get this done. There's a lot legal is involved in the revocation process, or in the even the proposed revocation. So we are implementing that. It's just starting and going, so that does take a lot of time. Like I said, I've heard a lot. I've heard the pros and the cons. why we did this, but I have to say that I am happy that it's done. I'm happy that it is a review of the program, and if it needs changes, the only way to make a change is to actually review something and then make changes from that. So I look forward to that part.
So just a quick follow-up, and sort of to your initial point, it's not very patient-centric. It's clear to me, glancing over this, that in fact it does appear to be primarily focused on the growers and the dispensaries, etc. And if you look particularly at figures, anyway, there's a bunch of them. Figure 3 has to do with dispensary regulations. Figure 4 with the processing sites. I mean, these essentially plummeted in the spring of 2017. Yeah, so I guess, I mean, I'm just sort of perhaps stating the obvious, which it does seem that dispensaries and production, etc., and I know there's been a lot of discussion about that, when a lot of those sites and dispensaries and retail establishments have gone over to OLCC regulation. What's left with OHA regulation really is more. There's certainly the medical dispensary part of it, but it's more focused on the card holders and the patient part of it that isn't really focused on in this report. So
I would say that our regulation is on the grow sites. We provide patients cards, but we're not really regulating the patient. But we certainly are charged with regulating the grow sites. And I think that's what we were trying to show in here, is you had this huge influx all the way through, part of 2017, where staff were concentrating on dispensaries and processors, and then they did shift to building the grow site inspection, to testing it, to before they implemented it and such. And so as far as a regulatory part of it, I would say that part of it is our growth sites. I think that I agree completely that on the patient part, I think that's part of what I would say, is this commission's group to come up with more, what we need to do as far as the advocacy for our patients. That's not, we administer cards, we get them out in a timely fashion. We make sure that we're, have professional, courteous people on the phone. We've increased our staffing to address the wait time on the phone. So we've done those types of steps that we have the authority for, but I think that any additional authority or advocacy would need to come through legislative change.
Were you suggesting that there is a different, is it the presentation report or just the content of it? You're thinking that we need a parallel report that was more focused on what's happening at the patient level?
No, I don't know. I guess I was just sort of stating the obvious, that as the retail market came on board, there really is, when it comes back to medical, when it started off, it was all medical cards. And then there got this whole kind of medical grow dispensary, et cetera. And when the retail market came on, now it's really more of the focus is on the card program. So I guess I was just sort of stating the obvious, that it's a whole report about kind of OHA and, is there a dual tracking system or not, or what we're able to do, et cetera. And I was trying to sort of state the obvious, which is, I know folks are concerned, how much of a dual tracking system, et cetera, when you sort of have, again, you already said regulating the product or the market or whatever is different than regulation is the wrong word, but when you're issuing cards and evaluating whether or not people have the, the conditions and all those kinds of things, implementing the card program is quite different than regulating the product, medical dispensary, etc. So again, I was just sort of stating the obvious that this report focuses on half of the work, or I don't know if it's half, but some chunk of the work, but not the work that has traditionally been the OHA work for a very long time and continues to be a focus of the OHA work.
Yeah, I think this was good for us to see because it actually gives me perspective. It sort of seems like the OMP's function was to oversee the seat access. The card program was just a facilitator for patients. From this report, and I guess from just observation, it doesn't really seem like the program was designed to cater to patients at all. And so I take Carol's point that this commission now has the opportunity to focus on patients, in part or in majority. We'll see how that sort of tease us apart. And I think that now it's our turn to take the baton and create a program that we want for our patients and everybody else. But thank you, this was great, and I think it illuminated a lot for me.
I just want to say that we actually did talk about the strength of our program was facilitating access to patients. So we did address that in here, just not in the main part. The part we weren't doing well.
Sorry, I just want to allow Pat a chance to say hello because I know you hopped on the phone. Do you want to introduce yourself?
No, I'm lucky. He's on mute. Anyway.
Patrick Lick. Another member of the commission has joined us. Sorry, Jess.
I just had one point to follow up on what Dr. Knox and others had said. Carol and Andre can correct me if I'm misunderstanding the statutes, but before 2198, the way I understood OMMP statutory mandate at least is it was somewhat silent on access to patients. What it does is it creates an exemption from criminal liability for individuals who meet certain requirements. There's nothing in the statutes to say those people must get their medicine. That says if those people have this amount of cannabis and they have the right card, then they're not committing a crime. That's really what it says. So
that's not, pardon me, but that's not actually correct. These people that are providing cannabis to other people, they serve a very clear function in this process. And I think we have to be very careful how we approach responding to this report and creating our own patient report. There are a lot of things at play in this report that were ignored. History, for one thing. This program originally was created to allow Oregonians to grow cannabis for their own medical use, and was later modified to allow for those after we discovered that people can't grow in their apartments because of rental agreements or because of Section 8 housing or whatever it may be. We created the statute, expanded the statute to allow people that couldn't do this for themselves to do it for others. These are the tenets of this program that over the history of these 9 pieces of legislation have systematically dismantled on the grower-patient relationship. It's horrible, it's cruel, and we just have to be really careful here. Everything we do affects patients. And as soon as we lose sight of that, we start making bad policy decisions, writing bad legislation, and advocating for stepped-up enforcement rather than stepped-up education, and bringing these patients into the fold where they can be educated about what they're supposed to be doing. These people that are out growing, they're growing for themselves and their partner. I'm pretty sure they're not clear that they have to report for what they're doing with that partner to the OMOS system. And as soon as they get 3 patients, whether it's 12 plants or not, they got to jump into the metric system. This last 3 months for patients, for growers, and the patients they serve has been tragic. Of the 1,900 grow sites that could have come into the system, barely 700. That means 2,000, 3,000, 4,000 more patients are going to lose direct access to free medication, and the responsibility for meeting the needs of those patients is going to fall back onto the state in one way or another. Whether it's emergency room visits, increased prescriptions, all those sorts of things that factor. That people that think about cannabis as just going to the store and getting some for patients completely miss. It is not about necessarily going to the store. That's important, of course. Access, local access, availability, affordability, those are all important. But the issues that patients face in the standardized medical community, we got to get on top of that. And so when we talk about the challenges and strengths of this program on the mechanical level of everything, how we do it, how we do the cards, how we do the inspections, all that sort of stuff is good. It's good reference. but it belies the underlying factor that the history of this program has been adverse to patient access, to patient services, and continues to be, and the systematic dismantling of the growers for other patients model in this program needs to stop. And we need to figure out how we make this work without destroying that. Nobody in the OLCC has stepped up yet to start growing for patients. No retailers, well, not no, but very few retailers have stepped up to put in place a patient program. But we got 700 grow sites. In fact, there were a couple of thousand grow sites that are willing to continue to grow for patients. And you're pushing them out. You're forcing them into an OLCC system they want no part of. And for the most part, given the exemptions they've been given for land use and water rights rules and regulations over the last 20 years, they can't even get into the system anyway in their local grow site. They can't get a land use compatibility statement, or they don't have water rights. And so we've got this large population of grow sites willing to grow for patients, and we need to do everything we can to preserve that. Thank you.
I have a couple questions for Carol, just real quick. So, of the 5,127 that are eligible or should be coming into the system as of July 1st, this is our first meeting in July, how many actually came in?
Are you talking about into the seed to cell tracking system? We had 700.
Only 7?
But they're not all required to. So we have OMAS. So the other, 5 of the 5,000, I think 1,200 is what we ended up with.
So, the last time I think about 1,300.
Okay, so about 1,300 of the 5,000 needed to go into the seed to cell tracking system. The rest of them are OMAS, meaning our monthly tracking.
And
so
can you,
about half.
Can you touch on what the revocation process looks like? I understand losing a license, but what's going to happen with the marijuana? I mean, that's, you just pull a license, but you still got a grow site in marijuana.
Yeah, that will be part of the actual final. So initially what happened is for the group that we are in the process right now, we sent out warning letters on June 6th to all of the growers at the grow sites, told them they needed to get in compliance reporting, create their grow site administrator account, and begin tracking by 7/1. After 7/1, we pulled the report. Those that did not do that, we began then putting together a proposed notice of revocation, and we're just beginning to send those out. Then from there, if they either settle or we have to move to revocation, that will be part of the revocation, is they'll have a stipulated amount of time to destroy the product and or return it to the patient. Excuse me, Shannon's right here. Return it to the patients. It is the patient's product. So, but they should not be growing out of that. Sorry, yeah.
I'm wondering if the members of the commission would allow me to go a little rogue on the agenda and just bring something that was meant to be in the second half up to the first half. And I would just remind you, as far as logic for doing this, part of, if you go back to 2198, part of our mission is to address the possible framework for the future governance of the OMMP, including proper oversight and regulation, blah, blah, blah. And I know we address a lot of these things piecemeal in our subcommittee recommendations, but every time I talk to the governor's office, they ask me, have we really discussed different models of running the OMMP? Have we looked at the way that other states do it and talked through this? And we keep on coming to it, and then I sort of push it to the next meeting, and all of a sudden it's July. So, and I think we haven't really addressed this head on. Are you guys, just given the direction that the conversation nationally went in, are you okay jumping into this? So the question is, most states that have legalized marijuana for recreational purposes have done what we did. So all of them had initially had a medical marijuana program, and then they brought in the recreational market, and those two programs are administered separately. But there are some exceptions. So Nevada moved both its recreational and medical programs under one authority, which is the Department of Taxation. And we should have a report on this. I don't know if it's on the Gov space. So I'll just summarize a few things. And then California, and the new recreational program in California will be brought under the same umbrella as the medical marijuana program, and they actually will create a new Bureau of Cannabis Control that will administer both programs. And there will be they will retain some functions that were previously done by the California Department of Public Health, specifically printing identification cards, maintaining a registry database for verification of qualified patients and their primary caregivers. So I feel like I'm not doing my work right today. So there are, there are different models, and I think what I promised the governor's office is that we would at least dive into this conversation with an open mind and talk through what would be the benefits of bringing them under one umbrella. Would that umbrella be the OLCC? And I think the appeal of that to the governor's office is that there would be some efficiencies, and to the extent that we are kind of ever negotiating for exemptions from certain fees or processes for medical marijuana patients, to be able to do that under one roof rather than cross agencies. I think it, or is it better to say that one new body could be a body that does not exist right now, and what would that look like? So I feel like everybody really has a strong gut feeling, but it's worth going through the exercise, and it's something that we'll need to answer to having had this conversation. So I wanted to start it now and get any of your initial thoughts.
And just to clarify, most medical programs around the country have been modeled after ours.
Yeah.
Exactly.
Yeah, totally. And it's just intriguing to me that, I know Nevada in particular was, it went under the Department of Taxation, so you can sort of see where its priorities lay, but they, in that state, have had conversations about how do we, like some of the newer states have said, how do we avoid what happens in state after state, which is the minute we go recreational, whoosh, the medical marijuana program goes down, and those people feel sort of disenfranchised. So I'm not, so even though everybody has modeled themselves after us, I'm not sure, I feel like we've all created kind of the same problems. And it is intriguing to me that California, the newest program, has taken a totally different approach. And I feel like in some ways, they were probably informed by what went before them. So I don't want to dismiss innovation because we have such a strong tradition.
So I'll start this off. And I'll caveat any recommendations I have in that I'm not considering any bureaucratic messes that may occur developing a new program, a new agency, whatever. So we have the luxury of ideas here and don't have to deal with practicality right at this moment. That's way, okay, thank you. Being a bureaucrat, I understand that it can be a huge headache developing all sorts of new processes and administration. So. My gut feeling is that we have a cannabis-only centered agency. So it's not connected to the Liquor Commission, it's not connected to the Oregon Health Authority, and that it's cannabis-centric. It deals anything from adult use to medical to patients. So that would be my kind of general feeling or idea.
So unlike Andre, I never had the luxury of ideas. I live in a state agency with a budget and with a workload.
But I'm confused by Andre's actually, to go back, because you warned us that you were about to say something that you didn't, might create bureaucratic nightmares, and then you just argued that we sustain the current. Yeah.
So my caveat was that I understand what Jesse's about to say. I fully understand that, and I understand the not only political frustrations, but the administrative frustrations, the budget frustrations. So these are all major issues that any state agency has to tackle when it's forming itself new and it's changing other state agencies. Setting all that aside, because I get to play that role today. Tomorrow I get to go back to frustrated government bureaucrat. It's my gut feeling that I think that we should have one cannabis agency, a separate agency that's not connected to the Oregon Health Authority, and it's not connected to the Oregon Liquor Control Commission. And it facilitates. I'll let Katrina kind of first.
Jesse's counterpoint.
I don't know that I have a counterpoint per se. I can see in a vacuum how that idea may be attractive, but in the real world, we're a state government that doesn't have a lot of resources. I don't know that OLCC was the right place to put this, but that's what Measure 91 did, and that's, I think the OLCC as an agency has been doing their best with the hand that they've been dealt, and it's working pretty well. Starting an agency from scratch is just extraordinarily expensive and inefficient. Who's going to work at that agency? Where are you going to put that agency? Who's going to buy all the IT systems? I mean, I'm coming at this from the perspective of starting this up at the OLCC in 2014, and even with all of the existing infrastructure that we had at that state agency, I have to tell you all that state governments are not good at startups. And they're just really not. And to start up an entirely new agency that doesn't have that kind of existing infrastructure to lean on, I think it's just unrealistic. Whether it was a good idea or a bad idea to put it at the OLCC, I'm not going to argue that point. I'm kind of agnostic, but just the inefficiency in starting a new agency is enormous.
So my very minor comment had to do with, I think one of the issues it's always felt a little like a round peg in a square hole. And so whether or not OMP should have been in the Oregon Health Authority, even I remember, I was around then, but back in the day it was sort of like, well, maybe it goes with the pharmacy board, or maybe it goes here, or what about, so there were a number of discussions about that. Again, our CARD program that's very patient-centered, at least for the public health division, is very different than the other work that we do here. And so my only comment, again, what Anthony said, initially it's a CARD program, but that there certainly were patients and growers, et cetera. Now what's happened with the retail market being regulated separate, again, it's a little bit of a round peg in a square hole when it comes to OLCC. And I think part of the problems that we're seeing is because it doesn't have a perfect home. So again, I'm sort of with Andre. I'm kind of saying this not as in my official role as OHA or state, government bureaucrat, but rather if we're looking, and that was my only point when I was commenting on the assessment report, is the obvious. So if data drives kind of program or policy, the data are pretty straightforward. What's happened to grow or dispensary medically focused? It's plummeted. I mean, that's what the data show. So the question is, are there problems and how does that solve or whatever? And so the one thing I was going to add, because Esther and I have been on the research subcommittee, is that our proposal, that's in front of you, and I know we're going to go over them a little bit, but basically that to advance research, you need essentially a center. We'll establish a cannabis research center. So I don't know that a cannabis research center needs to be in the same agency or whatever. And I don't know, Jesse, that they have to be completely standalone or if it could be under the umbrella, but quasi, linked to another so that you could share IT systems or something. But I'm totally with you. Again, I was here when DHS got split into OHA and DHS. Yeah. Well, that's what I said. And, we have the shared and blah, blah. Yeah, it's very difficult, even when you take a large agency and split it into two. But I'm just saying, I think part of the problem that we're coming up with is that this is not a perfect fit for any of the current state agencies that exist, because we all have slightly different kind of mandates.
Yeah, and I think in the bubble that I'm operating in with having the bureaucratic nightmares, I guess the first question is, should it be, I love being in academia, it's my own fantasy world. The first question is, should it be centralized under one roof? And then we could talk about what that roof is. You know what I mean? So that might be one way to address it as well. I'm sorry, Rachel, and then Jessica.
No, I 100% agree with Andre. It should be housed under one roof. That's what California is doing. Every agency starts at some point, so I wouldn't be afraid to start up a new agency for this purpose. I think the recreational or adult use system is young enough that we can get on top of that now and not have a headache 10, 20 years from now because we didn't do this right now while we're being audacious to address this issue. I could see, like hypothetically, if the OCC was that agency, licensing the OLCC to facilitate while we develop systems that could take over what the OLCC, maybe, or it just helps administer a lot of the services that we need to provide. but I do think it would be the right thing to do to create a new agency to oversee both.
So one of the, I think, most important things to consider when we're talking about this question, should it all be under one roof, is what is it?
Cannabis regulation.
But we might have very different ideas about what appropriate cannabis regulation is. And
That's what the agency needs to solve.
Before we fix those ideas, we might not know where to put it. You know, depending on if you want to regulate it like a controlled substance, OLCC looks good. If you think you want to regulate it like an agricultural product, ODA looks good. If you think you want to regulate it as a medical commodity, for lack of a better word, then maybe OHA looks good. But the truth is, it's all three of those things. And
well, let's talk about cannabis from a pharmacological and physiological perspective. It is a wellness product, right? It's a healing substance. That people recreate with it has opened this opportunity to sell it like a controlled substance, like not a controlled substance, but like alcohol, so which is a toxin that we allow people to purchase freely, and we regulate that, and adults can consume that, and we don't have all this chaos that we are experiencing now surrounding that. And so that was a choice. But cannabis is a healthful product that we have chosen to bifurcate into an adult use in a medical system, which makes no sense. So here is our opportunity to bring those systems back together. How a person chooses to use their cannabis, if they're 21 years and older, should be up to them. If they want to relax, if they want to wind down, if they want to enjoy some cannabis with their friends, that's their choice. But I think we really need to redefine what we think cannabis is, and I think we have that opportunity right now to do that.
cannabis is all of those things. It's also contraband. And I think
Not in Oregon.
it doesn't,
It doesn't matter. It very much doesn't matter.
by the federal government.
It doesn't matter what the federal government says. This is state stuff here. And you're going to have to get past what the federal government is saying. We are so tired of listening to, oh, it's against federal law argument, when it's not against state law, and that's what we have to work on. That's what we have to meld to protect it from onslaughts by the federal government, because it's contraband.
Anthony, irrespective of what you think about the federal law, the reality is illegal commerce in cannabis is a big, big business in Oregon and throughout the country. It's a big business that comes with associated public health dangers, violence, environmental degradation. When we're regulating this product, we need to think about...
Regulation has led to violence, not cannabis itself. The misregulation.
Illegal commerce in cannabis has led to violence and to legitimate harms to our society. I'm not bashing cannabis, I'm bashing the illegal commerce in cannabis. And I think any system of regulation needs to contemplate that reality.
Sure, but we have a system that has criminalized people, really unlawfully, against our Constitution. So I just, getting a little sensitive here because there's a lot to unpack in some of the comments you just made. From a social justice, from a racial equity standpoint, there's a lot to unpack there, so we have to be careful when we're having this sort of a conversation. But I think what makes the money? People, the consumer who's purchasing that, right? All this tax revenue that we're getting is because somebody's going to a dispensary and buying something. So really our focus needs to be that consumer, or that patient, or what I like to call them all, the patient consumer. Right? So we need to keep them in the forefront of our mind when we're making any and every decision that we do in this commission. All of our decisions, from seed to sale, have to be with that end consumer in mind. That is the market, right? There's a target. This is business, right? Federally illegal or not, Oregon is making a lot of money off of a controlled substance. So I take Anthony's point that, there's what we're going to say about the federal government right now is mostly lip service because we have a regulated market that's making money in the state right now. I think the state is okay with the sale of cannabis. But we need to redefine, literally, we need to redefine what that means for our consumers, our patient consumers, what that means for everybody in the seed to sale process. This really should be one centralized industry. Cannabis is cannabis, whichever way you slice it. It's one product that we're trying to deal like it's two different entities. It's sort of ridiculous.
So I guess, just to bring it back to what we're trying to accomplish this stretch of the, of the meeting. So with all of your different perspectives, how does, if we go back to the question of centralizing the governance of both of these programs, and thinking towards, because really what we're doing here is not just deciding what we do now, but thinking of the long-term strategic plan we have, which may be completely changing the way that we conceptualize cannabis, or completely changing it from the way that we've really talked about it as two very separate programs. But so from each of your perspectives, how does centralizing it help your chief concern, and how might it hurt?
This is Anthony. I think one of the big mistakes we did in all of this is not turning the cultivation over to the Department of Agriculture right from the start, and let them handle the cultivation of cannabis, marijuana, whatever label you want to put on it. I agree with Andre that we need an overarching commission or agency or whatever it might be that deals with cannabis as a whole, whether we're talking about hemp, whether we're talking about recreational use, or whether we're talking about medical use. This is what needs to be done, and we've got to get our house in the order. The part of what we struggle so hard with, for instance, immature plants under 24 inches. We've been arguing about this for years. We've argued about, well, once it hits 12 inches high and 12 inches wide, then it's a mature plant, it's not an immature plant. These conversations would have never happened in the Department of Agriculture. They understand plants. OLCC doesn't understand plants, and more importantly, they don't understand medicine and how cannabis is used as medicine. And their restrictive policies on transfers and patient availability from their producers is just obscene. It does in no way meet the needs of the patient. And so, in order to satisfy this, in order to get a handle on this diversion issue, and raise the level of competence of our participants and registrants and licensees, we have to have it all in one spot and get our house in order. OLCC handles wholesale and retail distribution of recreational adult use marijuana and oversees the manufacture, wholesale, and distribution of high potency concentrates, just like they do spirits. OHA handles the patients. Department of Ag handles all cultivation. We get to that point, both of those agencies are going to be streamlined beyond all belief. And the issues surrounding growers are going to become minimized, because we're dealing with people that when they walk out to a facility or a garden or a 40-acre, planting of cannabis, of hemp, they're going to know what they're looking at. And it's going to be a much less confrontational thing. This whole thing about trying to narrow the box and squeeze everybody into this box or that box is just not going to work. This is too big of an issue, too big of a plan, too big of a process to meet the needs of the consumers, meet the need of the patients, which should not be confused or conflated, and to meet the needs of the agricultural community that's forced to deal with it.
So when we were talking earlier about the problems with creating a new state agency, et cetera, actually right now there's a lot of duplication of effort. So I think, there's a flip side to each. And again, when I was saying round peg and square hole, it might be actually nice to figure out what a round hole is. So that, and again, what we're dealing with is a plant, except it has obviously many different chemicals. And I'm glad that you mentioned hemp, because it's got many, many different uses. And it just seems counterintuitive that you have same plant, if you will, that was being regulated or governed in, and like I said, a cardholder, it's the point well taken, not regulation, but people who understand the plant, the different uses, and I agree with you about all the various consumer groups, and I put that in quotes, whether it be the patient or people who want to grow hemp to, produce clothing material or whatever. And the fact that you have 3 different state agencies, and we all have very different approaches because our mandates are very different, whether it's to protect health, whether it's to regulate liquor primarily and now cannabis, or whether it's to promote agriculture in the state. And then we do have the whole research piece, which our subcommittee is really out there. None of us are looking into that, right? Because it's in nobody's direct mandate. So
or how to integrate healthcare professionals into the system. So
right,
research
so
into
again,
healthcare professional inclusion.
Yeah. So what I guess I'm seconding the voter. I am supportive. I do think that there are always drawbacks and it does cost money, et cetera, but as Dr. Knox rightly pointed out, the state is making a whole lot of money off of this, both previously the cards and now the retail sales of this. So there is a lot of money that's being gained from this product.
Yeah, and I do wonder, I can totally appreciate that there is this activation energy and activation investment, and I just wonder if we feel like there is a lot of duplication of efforts and inefficiencies that might be gained back if we bring it all under one roof, then it might be that the long-term, the long-term gains will outweigh that super painful early period.
So, where? Oh, I'm sorry, Senator, go ahead. I've been talking a lot.
I believe that theoretically Oregon could be served by maintaining the regulation of cannabis under separate agencies. I do think there's a lot of inefficiency right now. I'm not going to consider the bureaucratic nightmare. I'll let you consider that. I have a better feeling about Oregonians being served by a centralized cannabis agency. But I think what's crucial is that that centralized agency have a mandate to serve the most vulnerable low-income Oregonians who are losing access to their free and low-cost medicine. I think that's the greatest tragedy that's going on right now with the ongoing evolution of cannabis regulation. I think that the vulnerable low-income population could be served and their access could be protected under the current regulatory scheme. But I don't see that happening. I think the reasons why that's not happening are very complex. And I believe that the initiation of a new centralized cannabis agency would be an opportunity for a reset of policy, and one in which access to medicine for low-income Oregonians could be guaranteed, supported, and improved. I think that's more important than, I think that's the most important issue in front of us. I think it's more important than commerce and diversion. Obviously, some parties in the United States are very concerned about diversion. I don't really want to get into the arguments about diversion. I think, again, all of the public harm that comes from diversion is, I think, primarily, as Rachel was saying, primarily stems from the regulation itself. We can see that with the history of alcohol prohibition. Those are my comments. Thank you.
So I'll attempt to limit my comments to the issue of bureaucratic efficiency and redundancy of efforts. I think if, for example, medical and recreational cannabis regulation were housed under the same agency and regulated to the same standard, you could have enormous efficiencies granted. But if the policy decision is to continue to regulate to different standards, I really don't see the point in putting it in one agency. At that point, you're not removing inefficiency, you're just kind of locating all the inefficiency in the same address.
They should be regulated to the same standard, right? If we're concerned about public safety, then all those products should go through the same rigorous testing standards to make sure we're delivering the best product, because we don't have the numbers on this. But I'm sure if we do start capturing this, it's going to be quite illuminating. A lot of these recreational producers are using their cannabis for health purposes, right? So when we have people who can't qualify right now because of our limited qualifying condition list, are now going into retail shops buying stuff for a medical purpose, and they get a product that doesn't meet medical or in therapeutic grade and strength standards, well, then we're doing a disservice to, again, that patient or consumer. Like, we have to be really realistic about how people actually are using cannabis. It's not just for this recreational purpose. People are seeking it to use it for either a wellness, therapeutic purpose or a targeted medical purpose.
And those products that they buy at the OLCC store are tested, unlike the products they get from the grower.
But you can make the same argument at the farmer's market.
Yeah, absolutely.
Right? I mean, we're trusting the local farmer to provide us with foods that are you know, appropriate for human consumption. We make that assumption in the grocery store every day. We're buying products on the shelf full of chemicals that actually do harm us.
Well, I mean, come on, it's a bit disingenuous to say that an apple at the farmer's market is the same thing as a psychoactive cannabis plant. You know, it has thousands of chemicals that, you know.
Do you know how many things we can buy at the grocery store that have psychoactive components that are very harmful and toxic to people?
Now this goes back to how we're going to regulate cannabis, and I think, you know, we regulate it 3 ways right now. It's, you know, whether you like it or not, it's a recreational substance that people use to recreate. It's also a supplement that people use for wellness. And it also could be a possible actual medicine that people use to target specific diseases for specific outcomes. That's very, very limited right now because the research is so thin. And really
Andre, what do I do for a living?
If I have adenocarcinoma of the lungs,
come see us.
What molecule in cannabis is going to specifically target that particular cancer cell and kill it?
CBD, THC, a multitude of terpenes.
According to what
proven.
Okay, we're getting. According to what clinical trials?
Oh, would you like me to pull the research for you?
Please do, and please bring them to this committee for us to look at. The point is that the plant itself has so many uses, and it's a broad plant, right? It can be used, like I just said, it can be used like on a Saturday night if I want to feel good with my friends. It can be used like a vitamin C supplement if I wanted to. And it can also be used as a targeted medicine as well. So, you know, please, let's like refrain from generally just calling it medicine all the time. Because it's unique, it's different.
No, from a physiologic level, that is what it is.
That's
Just
right.
because you choose to recreate with it does not dismiss its nature.
Endocannabinoids.
Okay? This is science. This is why it's been a mistake for people to even conceptualize the use of cannabis as a recreational product.
I think my point was, before we got off on this, is that I think a single agency will allow that agency to focus on cannabis itself for whatever purpose it is used for. And whereas if it's located in different agencies, OHA is looking at it from a public health perspective. Sometimes it focuses too much on the negative outcomes of public health. OLCC looks at it from a controlled substance, contraband perspective. ODA looks at it from an agricultural perspective. I think one cannabis agency can look at it from all the different perspectives that we think cannabis is. Now that's my point. So I didn't mean to degrade that into a debate.
Jeff?
No, I think that's beneficial.
Then law enforcement must be on the record saying the same thing that we've been saying for years and years now. It needs to be housed under one roof with one agency. The right hand does not know what the left hand is doing in this state. It's making it very difficult for police officers in this state to enforce the law.
Yes.
Well, police officers and law enforcement organizations in this state take second seat to the agencies in enforcing these laws, and you only get to come in when they're called in or you find yourself in the middle of a situation that you have to respond in a law enforcement manner. You guys take second. This thing about these law enforcement agencies getting access to these lists so they can go out and identify where every single marijuana grow site is not okay. There's a lot of these grow sites that are being that are growing patients for medicines that don't want people to know where their medicines are being grown, or don't want people know that their medicine is being used to help with their HIV situation, or whatever it might be that's, you know, private. And so, again, we have to, I know it's contraband, I know it's a Schedule I, but the only way we're going to make this work is to, one, expand the market so everybody has access to it, and step up our educational efforts. physicians, for the patients. The patients have just as much responsibility here. We tend to think we can smoke wherever, whenever, how much we want to smoke. And we've got to change those perceptions of how we do that as well. But I do agree, and I think we need to figure out how to put it under one agency. And the tricky part is we keep going back to enforcement. It's starting to look out there right now, especially you go into California, it looks like 1985, 86, 87, where large law enforcement operations are coming in and ripping up 2,000, 3,000, 4,000 plants at a time, just having a great old time. And this is in a situation where the rules are still very nascent and they're still struggling to understand it. We have the luxury of having been doing this for a while. And when it comes to patients, the number of patients in California, because of the way we approach regulating cannabis for adult use, has dropped from 900,000 to 90,000. And that just illustrates what kind of damage a recreational program has when the agencies are unwilling to answer the question, now that marijuana is legal for adult use, why do we need a medical program? Well, we got a lot of reasons why we need a medical program and why it needs to be dealt with as a medical program with patients that use medicine. We have people in these state agencies that still don't recognize it's medical. So that's all I have to say.
So I think what will be interesting to me is as we move forward with our agenda and talk, go through each of the subcommittee reports, it might be interesting to inject the idea of a centralized agency into those, into each of those topics and talk about, are there ways in which the objectives that you lay out would be facilitated by a centralized agency, either in the short or long term? I mean, I can imagine for us that there might be some answers in the research subcommittee. I do appreciate, though, there's this whole meme on social media about what is the most ambitious crossover project that has ever been done. I feel like I can see that this might be a really ambitious crossover project. And so I guess my last question for you before we have to move on is there information, data, stuff from other states, stuff from our state? Is there any other data that any of you would like to inform our potential recommendation of centralizing this effort under one roof?
So this data is not available yet because the CTS tracking of OMFD growers is so new. But 30, 60 days from now, I think we'll have a lot better picture of how compliance is going on the OMFD grower side, and that could help inform us as far as whether it's reasonable to expect that this population can be regulated in the same way that the rec market is.
And just for clarification, we didn't mention the state of Washington, but didn't Washington bring alcohol and cannabis under one commission? Am I correct?
Yes, they're under one.
Yes.
And that's a model that I would appreciate more information on.
Well, Jeff, they originally had a program that's a patient program, much like California's, where you went and got a doctor's note. That was good. But then when they legalized, that kind of fell by the wayside, and then they readjusted and created a patient card program similar to ours. They're still struggling with it. But it always gets back to this question of the difference between patients and consumers. And until we can come to an agreement on what those two demographics look like, we're going to be swimming in deep water.
But I'm sorry, Jeff, just to clarify, so you're recommending that both recreational and marijuana?
I just wanted it on the record that it's been mentioned here that maybe OLCC is the place.
Oh, I see.
To start this. Maybe it's not, there's different opinions at the table, but Washington did combine both cannabis and alcohol to regulate both markets.
And it's not going so well.
The medical market.
That's why I asked. I said I would like to see more information about that program.
Yes. In Colorado, I mean, they're both under the Department of Taxation and Revenue there, but it's an umbrella organization that houses both cannabis and liquor as well as a few other things.
So I wanted to make one comment to what Anthony was saying, which he said, make a distinguish between kind of patient in the medical market and the retail and consumer. My feeling, and I'll use that word on purpose, but is that there's a huge amount of overlap, that there are a number of people who are buying product on the retail market because they don't want a card, but they're using it for arthritis, etc. And forgive me, but I'm sure there are people on the medical market who are using it primarily for medicine, but also are liking the psychoactive effects. So I think it isn't quite as simple as patient using it for medical and retail using it for, the psychoactive effects on, with friends on Friday or Saturday night. So right there seems to me that that's one of the difficulties, is that there's not a clear, bright line. It's similar, not identical, but it's, one plant with a lot of different characteristics. But, and then again, the patients, there's no bright line between medical and retail.
So but we could come up with a few pragmatic approaches. I mean, making sure everything is food grade, so appropriate for human consumption is one way to make sure all products are appropriate for use. And then there's therapeutic strength, right? That's what's going to differentiate between something that's therapeutic for a medical condition and maybe something that's a little more supplemental. And if it has a certain quantity of THC, you can get euphoric with it. And so for me, and maybe a very simple way of looking at this would be the modern pharmacy. You have over-the-counter and behind-the-counter varieties of products. You differentiate them between their therapeutic strength, not grade, because they all should be of a therapeutic, medical, or food grade, right? But we have certain things at different strengths. And maybe at certain strengths, you have to have that medical oversight. You have to access those products through a provider who writes you an authorization. It's particularly important when we're talking about children, right? Somebody under 21 would have to go through a medical provider to get authorized to get the behind-the-counter products. So
That just makes sense for the buds and whatever. I mean, that makes sense for concentrates, extracts, except for
that makes sense for flour too.
For the record, what you just described is exactly what we have in the OLCC retail market. It's all, you can argue that maybe the standards aren't correct, but it's all tested to standards. All the food products go through ag certified facilities, and we've got a system where medical card holders can get strong products.
Right, but we're suggesting that we take that away from the OLCC.
Yes, absolutely, and that
we're a centralized agency.
And Dr. Knox, that we step it up to, because there's a lot of people out there growing medicine for patients right now, but those people have such great knowledge and experience in doing this that certain segments of them could get a special endorsement that had much stricter criteria that they had to meet to get it closer to a pharmaceutical grade. So we have this small segment of growers growing specifically for pharmaceutical applications, or as close as we can get it, so that like when the assisted living facility calls up or Providence calls up for some oil, we're as close to pharmaceutical grade as we can get given our limitations.
I just want to remind everybody here, coming from the perspective of a regulator, the more you regulate something and the more that you ask it to be up to more stringent standards, the more expensive it gets for those that can't afford it. That's the situation we're in with the pharmaceutical industry in this country right now. Cannabis is the people's medicine, and it got here not through an approval process through the FDA, through research institutions. It got here because people went to the voting booth and voted. So I think this is a very, very difficult and nuanced position that we're in, is that we want to ensure access that's affordable for patients, but we want it to be effective, we want it to be safe, and we want it to be up to these standards. So we have a really, really difficult task with a lot of competing interests here. So I don't really know where this discussion was going. I was just trying to put a little bit more perspective into it.
What are you up for?
I'm turning 40 this year. I've got another good 25 years of work. So yeah, I got a career to build, so sure.
Yeah, and I am intrigued by when you're housed under one roof with a coordinated mission, how that conversation can go. I mean, it can be totally Westeros in there, but still, you're all, Game of Thrones reference. I imagine like this can happen, you know, yet what would be the fundamental difference is that you're all working under one roof with a single or, you know, sort of the same short list of purposes rather than actually being housed at different agencies with very different fundamental missions. So this definitely intrigues me. So I guess the question for you, since we need to wrap this up and maybe take a bio break before we move to the second half of this meeting, but you're reaching for your button, Jesse. Did you want to say something else?
Well, I mean, the point about a coordinated mission, I think, is a very good one because that's something that the legislature has been trying to figure out for the last 40 years, and they failed. You know, so I think putting it on individual agencies is a little bit unfair. This is something that needs to come top down, and as we have heard in the preceding 45 minutes, there's a lot of different viewpoints, and it can be really, really hard to reconcile things like patient access and preventing illegal commerce. So, to me, it's almost immaterial whether it's in one agency or 3 agencies. The first point is we need to figure out what we're doing. Sorry.
I will say part of our mission is not only do we recommend a potential framework, but we also fit ourselves in there somewhere. You know, what is the role of the commission going forward on a long-term basis? So there, you know, there is a role. Like say we didn't immediately recommend centralization. Is there a role that we can play that could better unify, streamline efforts across these agencies that all have a piece of the beast? And again, with the singular focus of trying to improve access for patients, since that's why we're here. So I'll just throw that out there too. So I guess the question is, how do we move forward? You know, we kind of have a limited amount of time as far as our objectives for this year. We could take all the notes from this meeting and we could put together, you know, just sort of like a summary of the opinions. And I mean, I felt like the majority opinion was that some sort of centralization would be beneficial to all of the concerns and objectives we have about this program. So I feel like I could summarize that, but definitely include, you know, some acknowledgement of the nuance that this is not like a simple, straightforward, just like snap our fingers and it's going to happen process. And that there may be ways to sort of do a stepped approach to this or something like that to make it more feasible, like housing it under one place first with the intention that I don't know, you know, the intention that it go independent at some point. Katrina, do you have kind of recommendation for next steps?
Yeah, and then I know Anthony too, but again, sort of thinking about, so we're supposed to do a report to the legislature. We had 4 subcommittees that met, and when Jesse's talking about what the it is, I actually think it's very similar to these. We did the legislative one, there's a training one, and we talked about that, whether it's training for patients, providers, who. There's patient access, we just spent a lot of time talking about that, and then there's product regulation, product integrity, I guess is what it's called, but it's still, so to me, that's kind of what, we've already defined what the it is. It's patients, it's product, it's research, it's, you know, and it's education and training. So sort of thinking about how all of these would fit under a larger agency / board or whatever, I think we're a lot of the way there. We're not 100%, don't get me wrong, but I think that's the answer to what it is what we've been working on for the past 3 or 4 months.
Yeah, I like that. Maybe it'll be as we go through each of the subcommittees this afternoon, and maybe like, you know, a sentence or 2 in each of them, sort of talking, or a paragraph talking about what, you know, how some of these issues might be addressed by centralization. I do feel like there may be just one summary section where we talk about sort of just centralization across the board and how that might happen.
So I'm just trying to clarify kind of our purpose. So we have our legislative recommendations, which we were asked to do via bill. We also have our long-term strategic plan for the future governance of the program, which is, you know, related, but I think kind of a little bit separate than our initial legislative report. So I don't know if we keep them separated, or do we try to you know, I'm just trying to think of like organizationally, you know, how you write reports and papers, and if we're going to make the recommendation that we have a centralized agency, I would like to keep that discussion high level, and because we obviously have very differing opinions on the mechanics of it and how specific we should get. So I kind of want to remove the ideology and kind of the personal feelings from that and kind of go from more of like this aesthetic high-level view of like, we should have this larger kind of one centralized agency. It will do these certain things, you know, make sure it looks out for patients, make sure it cooperates with law enforcement, make sure it regulates the product, make sure that it educates physicians. You know, so like that, addressing that in the overall concept and then getting into the specific legislative recommendations. I'm just kind of trying to throw that out there so it's organized, at least in my mind.
Yeah, and I guess I stand corrected slightly. Looking at the legislation again, what it says in section 4 is a framework for the future governance of the OMMP. And so what we've been talking here is not just the OMMP part of it, it's the broader. So and again, that's a little bit to your point, Esther, what's the future role of the Cannabis Commission? We are not the Oregon overall cannabis, you know, it's really, we're focused on the medical cannabis program, right? So again, is there something slightly different? So I just wanted to be clear.
Yeah,
sort of echo broader regardless, but we really are focused on the medical aspects here and how that works.
That's totally true. Although in section 6, in part 2, it does make a nod to providing advice to the OLCC.
Yes.
And then some other things about the long-term strategic plan. And I think to the extent that we talk about the benefit to patients of doing something like centralization, I think it's okay for us to wander a little bit as long as the focus remains the same. And helps us accomplish some of these other objectives. The other thing I'll say is just talking to Jeff Rhodes last week, he did clarify that there, at least from his perspective, there really is no place for us to make legislative concepts, but really that this should just be a report with some very clear bulleted recommendations, and that those would be amenable for somebody to sort of pick up into legislative concepts, but there's really no placeholder for us per se. They have one related to cannabis, but it's probably not going to be just like, you know, picking up specific LCs from us. So he actually he said he had a model for something that he think would be a good structure for us to use. He just hasn't forwarded it to me yet, so I poked him for it again. And I think I described kind of the content of our different reports and LCs, and he's like, it sounds like all of that could just be formatted a little bit differently, but that you guys all have very clear ideas of the kind of things that you'd be recommending. So.
Yeah, I would kind of concur with this conversation. We come at it with the status of the program. More patient-centric than what this report was just about. Long-term goals, and then suggested amendments to existing statute, small ones that can be accomplished, you know, focus on some of these things that can be accomplished simply. And then once, you know, we get past the September deadline, then I think the subcommittee should continue to work to flesh out some of these concepts into some suggested amendments. I've seen that starting to happen already, and I think that's a good way to go. Because we really do have it's a big job, and there's a lot of moving parts.
Okay, I move that we actually take a little break right now. Are you okay for the 10-minute break, and then we'll come back to subcommittee reports?
So moved.
Thank you, that's the first section of this meeting. We'll talk to you in a few minutes.
Yes.
Business is good.
Did you look at that? I feel like I skipped over a part on the agenda where we talked about the GovSpace documents. Do you want to?
Sure. So I also help in update the website for the commission. With that, adding agendas, meetings, whatnot. GovSpace, there's documents where commission members post documents that they're sharing among themselves, but the public does not have access to that. We can't just grant everybody in Oregon access to GovSpace to look at all those documents. So trying to come up with a system to allow those documents to be seen by everyone else. My thought, and Jen McFadden's kind of been working on this. There's the overall commission, GovSpace space, and then each subcommittee, or at least 2 of them so far, have their own GovSpace as well. And those subcommittee members can share documents among themselves. So I just wanted to bring forth to the commission kind of an organization on how to share those documents within GovSpace so that I can then take them and share them with everyone else on our website. So my thought was to kind of create packets of anything that's posted after a meeting until the next meeting as a GovSpace packet for that subcommittee or for the commission in order for the public to view what's been shared. And then the same with any materials that are shared during meetings. So I just wanted the commission to make sure that was okay with them, or if they had other ideas on how documents, or how they want documents to get shared.
So I have a question for Shannon.
Shannon?
Which one?
So, you know, I'm well aware of the public meeting laws, but there's a significant lag time for the commission members really need to read these materials ahead of time, before, you know, so they can come to the meeting prepared. And admittedly, sometimes I don't. And there's also the need for the public to get the materials according to the law, so it's about a week, I think. Is that what's... You have to notice a public meeting, and then you have to have the agenda and materials at a certain time before the meeting occurs. So I guess what I'm asking is, when the materials are distributed to all the commission members, do they have to also be available to the public to review at that same time?
I do not have that knowledge in my head right now, but I can research that question and get back to you.
Right, because yeah, I mean, the minimum I think is a week to have an agenda out, like 7 days or something to have the agenda, or 5 days, I don't know, you know. 24 hours now? Okay, well, now we have differing, we obviously need some research into the law. Yeah, because I feel like it's okay to give the commission members all the materials a few days before we post the materials to the public. I mean, nothing is going to be secret, right? It's all public, and we're all going to discuss this out in the open. So I was just kind of wondering the time chronology here of when we can release to the commission, and then when we can release to the public, and if we can give the commission members enough time to digest that material before they come to a meeting.
One other thing, I was wondering if it's possible, because I know we've done this with our subcommittee meetings, but I think we should upload all the audios. Right straight, just upload. OLCC uploads all theirs.
Do we have?
You know, for the subcommittees and everything. I mean, if it's not too much work. And then that way we've got a chance to review, because we had a situation arose where our minutes, we had to go back and reevaluate and then reapprove. So I just wanted, if that audio tape's available, it really helps facilitate some of this stuff.
I'll speak briefly to how the commission that I staff handles these documents, and then maybe if Shannon does the research and tells me we're doing it wrong over there, we'll know how to do it right. But I think we have treated public records differently. When informational materials are sent to our commissioners, we treat those as public records, not as public meetings. So, we send out materials maybe a week in advance of the commission meeting, and those are all subject to public records request. If anybody asks, we will provide them, but we don't proactively publish any of those materials. We don't consider them a part of the meeting necessarily.
Right, I mean, that was going to be sort of the question that I had too, Andre, with your question, was whether or not, I mean, you have to notice the fact that a meeting is occurring. I don't know that there is a corresponding law that says that you have to provide the public access some time period before to any documents that the commission is going to hear. Of course, if somebody wants to make a public records request, they can. But I'll get back with the legal answer for sure. Okay, let's move forward then. So I think it would be nice to get an update from every subcommittee. Next, a summary of the report, and I know we've been calling them legislative concepts. think we'll convert them to sort of bulleted recommendation points. And I see Jeff actually just sent me a document, so I'll circulate that to the whole group, or we can post on gov. Wait. GovSpace. I forget. .org. The GovSpace. Sorry, yes, Jeff Rhodes. I'm sorry, Mr. Rhodes. All right. So, does anybody want to volunteer to go first, just so I don't feel bad calling on anybody?
All right, I am representing the training subcommittee, and we compiled a few pages here for you folks to review, which is in the fashion of a report as well as legislative concepts, so it's all sort of blended here. But really, I guess the high-level recommendation that we have is to train healthcare professionals in the science and clinical application of cannabis so that they can be of service to themselves, their patients, and to improve the OMP authorizing process. We do want to broaden what is considered an attending physician, and instead of calling our providers attending physicians, to call them attending providers. We want providers who function in the capacity of a primary care provider, so that extends to nurse practitioners, naturopaths, and there are PAs, people who are trained and licensed to oversee medical care of patients, to have the autonomy and the authority to qualify patients for the use of cannabis. We also want to improve the authority of the medical provider through training. So the whole goal is to get, bring providers up to speed with medical relevance so that they, in their own opinion and professional opinion, qualify a patient regardless of the medical condition for access to cannabis. We really want to help broaden the application of cannabis because we know that cannabis can treat more conditions than our limited qualifying condition list. There's a lot of issues going into, how we can merge with the research committee, how we can improve quality of product. A trained physician who's giving the same medical advice to patients who are using the same products can inform cultivators and processors, et cetera. The whole supply chain can improve just training a clinician to provide standardized care to patients across the state. So a lot can come out of that, but in order to do that, we have to broaden the scope with which advanced care providers can work with patients. What else? Mike, anything I'm missing?
Grade and the provider's authority to allow limits that are.
Oh yes. And Jesse will know what we're talking about here. Currently, and Anthony brought the subject up too. For patients to provide or to acquire the amount of cannabis necessary to treat certain conditions and in the modalities that they choose to, like juicing or making oil, they do require higher amounts of cannabis in concentration or raw material. And when you have trained clinicians who understand how to apply the science to clinical outcomes, when they have that level of competency, they can make the recommendation for a patient with respect to how much is appropriate for that patient to acquire or to have transferred to them. And so we do recommend that under the assumption that clinicians who are working with patients have gotten this training, then that opinion supersedes the OLCC or any other governing body with respect to how much a patient can procure. And I think I mentioned your other point, Mike. So Mike's on the subcommittee with me. I didn't want to go through everything because this is a lengthy document here. Let me just make sure there's nothing else.
Bottom of page 6, Rachel, the grade versus the.
Oh yeah, when I mentioned this earlier, yes, we want to, a lot of our recommendations, our legislative concepts want to amend or eliminate or add some things to statutes. One of those is defining the difference or differentiating between food grade product, which I discussed earlier, and therapeutic strength of product, right? Like I said, we want everybody to benefit from a food-grade product for basic safety purposes. When we're talking about treating medical conditions, where we move from grade to strength, you know, how concentrated is that product? And so we think that that needs to be a little bit more narrowly defined in statute. And you heard this our first meeting. If you were here for our first meeting, we do recommend a global change to the word marijuana, to use the scientific term cannabis. And I think if we do succeed in, you know, seeing manifest a centralized agency, I would recommend adopting the word cannabis as opposed to marijuana and eliminating that from all statutes. All right, give me one moment and then. That's it.
Any comments from the commission?
Of course. I think that all of those to some degree are really good ideas. Dr. Knox, I'm a little, first of all, I'll say with expanding recommendation authority to advance nurse practitioners, PAs, and naturopaths, I would be agreeable to that. I would just think that the statute would have to then be consistent, because I believe that cannabis is a Schedule II substance in the state of Oregon, and that I'm not sure PAs, and it's not, is it unlisted? It's descheduled?
Yep.
Not a problem, then my concern goes away.
Well, in response to that, a lot of times those types of providers are overseen by an MD or a DO anyways. But this really ought to extend to independent nurse practitioners and naturopaths too.
Sure, and I would totally agree with that. I would just want it to be consistent that if they can, and if it's not a scheduled substance anymore in the state of Oregon, that doesn't really matter. It's a moot point, but it was that it'd be consistent, because I know in certain states, like an ARNP or a PA can't prescribe above level 3 or Schedule 3 or whatever. So anyway, that's a moot point. As far as removing the list of conditions in statute, I've never felt good about that list. I've never thought that the legislature should be in the business of saying, like, it's just too much subject matter specific that the legislature is not the place to determine how medicine is prescribed and to and for what. So I generally agree with that policy statement, but as someone who practiced law, prosecuting physician licenses for the inappropriate prescribing of opioids and for not meeting the standard of care, I would want some assurances better than the language that we have here, which is in accordance with professional judgment, that there's some assurance that if you inappropriately recommend cannabis or you over-recommend cannabis for inappropriate, uses, that your license will be at stake. And I think that's generally the case in the state of Oregon anyway, but I just don't know if the enforcement is there. And I think that the enforcement is not there.
To your point, I mean, it's coming. The medical malpractice insurance is emerging for the providers who specifically authorize or counsel on the use of cannabis.
Right, and medical malpractice, that is a civil matter, that's not an administrative matter with the license.
It's going to inevitably overlap, though.
So I would my recommendation would be is maybe have some stronger language that says in accordance with the standard of care, or in accordance with the community standards of care, or something like that, that has a little bit stronger, that is a warning to these practitioners that if you over-recommend or if you inappropriately recommend, that there are going to be consequences for that. And that's just my concern here, but I definitely think that I don't think medicine in this way should be legislated in the way that it has been.
Yeah, and to be clear, I mean, in this prose somewhere, it addresses that the structure of the training will be based fundamentally in standard of care.
Yeah, or maybe even add something like in accordance with known science and research on the uses of medical cannabis. That's the way, like, I might be wrong.
No,
I
you're
might
right.
throw something out here, but like, you can't get cannabis for a hangnail. I mean, you conceivably can because it's painful.
You actually can.
Yeah, it's
right
painful.
now.
For sure.
Yeah.
And I think that the way that you can get a medical cannabis card in Oregon is pretty broad. Like you can pretty much have anything, like any Oregon, you can get a card. Like it's.
That's not true.
The symptoms are pretty broad. Chronic pain, you know. So.
Yeah, I think just the language can be used for any condition that AP, sorry, this is page 7, believes can be mitigated with cannabis. I think like the language believes is a little bit too open-ended for me too, you know, because some people may believe it's great for bottom of page 7 for teeth whitening or, you know, I mean, I think just the language, you know, Andre suggested about
Not just language has to be.
not just what they believe, but what we know to be true or what standards of care dictate.
But I think overall, I think it's a good idea. I've never liked and felt comfortable with specific conditions being listed in statute. I just thought that's not really the place for the legislature to do that. And I understand because it was a federally prohibited substance and states have to get there somehow, but I think we're past that at this point.
Definitely, which I think is the overarching point. But when I read through the process it takes to, you know, petition a specific condition and to get approval, just way too involved.
No one has successfully done it in the 18 or 20 something years of this program. I don't admit, well, that was a legislative decision, not an administrative one by the agency. So no one has successfully petitioned OHA for a condition.
The section above, where you suggest 2 new sections.
It was ready.
That part 1.
Just one of the sections is new.
Oh, I see.
Yeah.
But I just create 2 new sections.
Section 1 is original.
Oh, I see. Section amended. Oh, I see. Okay, because I was wondering about the retention of marijuana, but you changed it. Okay, my mistake. Thank you.
So, a couple of comments. The adding of other people that can prescribe. I know in 2017, the naturopath had a bill in to address that. And what has always happened is whenever it says a doctor shall da-da-da-da-da in statute, they've always gone back to that one statute. And that doctors and DOs, that's it. And so, yeah, I really support this, especially out in rural communities where it's a PA or a nurse practitioner that's, you know, doing all the medical stuff, seeing the patients and all that sort of stuff. So, yeah, that is really a critical thing that we need to address. Oh, but I will say that the naturopaths got brutal pushback from LOMA on that. So, just a heads up on those efforts.
Why?
I mean, I support them, but
What was do you remember how they got brutalized?
well, they just, you know, I'm not, brutalized was maybe a little harsh, but the LMA just stepped in and said to the healthcare committees, no, this bill's not going.
Well, I think to your point, we want to improve access for patients, and the only way to do that is to broaden the number of providers, the types of providers who can authorize. And again, we can't use the word prescribe. We don't prescribe, right? We authorize, so we grant access, and we might counsel, but there's no method, there's no mechanism to like prescribe cannabis as you would another prescription drug. So we try not to use that word. Technically, doctors cannot prescribe any Schedule I substances. I know it's not the case in Oregon, but in general, so a lot of physicians will give pushback to that word, so just to be sort of clear. The other overarching point in training providers is to get more providers involved. You know, the most common complaint I hear from other healthcare providers who are curious is that they don't know anything, and if they knew something, they would authorize and they would counsel, or they would refer to somebody else in their community who they trust. So I think, you know, our goal is to improve patient access, not just through, you know, qualitatively with respect to the product or affordability, but providing them with clinicians who know a thing or two about cannabis and can help them more efficiently use their medicine, because based in science and physiology are helping them finely tune what they're using, how they're using it, so that they can get the outcomes that they're achieving and not waste a lot of product that turns into more dollars spent at dispensaries, et cetera. So I do think the success of our program does hinge in part, just in part, on improving the competency our healthcare providers, not just MDs and DOs, but all of our providers in clinical cannabis care.
Yeah, I was just curious as to whether the, any pushback was because of just a different training or background, but maybe, because you've explicitly addressed training and certification, that might be more politically acceptable now, or maybe just passage of time. I'm just wondering if we knew what the, I wonder if there's any way to dig up what the resistance was, just so that we can address it explicitly. Just a thought.
Well, part of it is having so many people out there authorizing people to have cards. And the OHA has never been particularly aggressive in monitoring the clinics. I know that the Compassion Center in Eugene, Oregon called several years before they finally closed their doors, but they called to have their records examined so that they could avoid one particular piece of redundant paperwork. And OHA had to sub it out. And so this goes back to part of what's wrong with this report that came out is OHA is sat on the sidelines. We would be in a whole different place if 10 years ago the OHA had gone to the legislature and said, we've got a lot of concern about all this marijuana leaking out of the state from these medical growers. We need to tighten things up. We need to do this. We need to do this, that. MIA. And so now we're in a situation where the OHA would like, and the state would like to hand off all this cultivation of marijuana by people growing for others over to the OLCC and be done with dealing with growers and growers growing for others. So, just, we got to exercise caution here again.
On a related point, it seems like the sum of some of these recommendations is that you're going to have more providers offering recommendations and for more conditions, potentially in larger amounts. And I'm not necessarily opposed to any of that, but piggybacking on what Anthony said, historically we have not regulated these providers appropriately. I mean, with all due respect to Dr. Knox, not all the doctors out there are like you. I think we know that there are card mills out there. So I don't know if this falls under training or if it falls under oversight, but I would hope that with the expansion of the number and type of providers, that there would also be expanded oversight of those providers.
Training inherently gets the ball rolling on oversight, right? So if somebody who's authorizing has to be trained first, well, then at least we know that first point of contact. We could sort of track where things might have gone wrong with that clinician if things do go wrong. But the goal is to standardize training so that we're all speaking the same language. We all care to the same standard so that patients don't go to one doctor one year and get one set of advice and go to a completely different doctor the next year and get a whole other set of advice. That's what's occurring right now, right? And that's a big problem.
Regardless of your condition.
So my question would be, would the educational credits, whether they're CMEs or continuing learning education, whatever they are, would that be a prerequisite to being able to recommend cannabis?
Yes.
Okay. I mean, I like that idea.
And in all fairness, I received the document on my write-up today, and so I'm just listening to the conversation, and I will read it when I get back home, and I'll provide you with feedback at a later time.
Yeah, I was just kind of sitting here thinking about what exactly we're doing here, and some of it is, we've gone over this iteratively over the past few meetings, so some of it sounds familiar, but as far as like the exact document, I myself didn't have a chance to go line by line. So I think it's still helpful for me to hear from each subcommittee, hear their summary, have a chance to talk through just some gut responses to it. But I think between now and our September meeting, the homework will be, make any edits that come with our discussion today, including maybe reorienting some of our reports to include the concept of a centralized, agency. And then before we meet for the very last time, we've all read and had a chance to go line by line through all these things, and that will be the expectation for the September meeting. Does that make sense? Yes. Okay.
Yeah, and also, sorry, the formatting of this changed a little bit, so if it's sort of flushed together and confusing, I apologize, but it's a formatting issue.
Well, I'll say if we are,
These number ones, it was not intentional.
it may behoove us, I know these are legislative recommendations in a report, but it may behoove us when we're talking about expanding clinical authority, that we go to the medical board, we go to the nursing board, because those are the regulatory agencies that will be tasked with enforcing the standard of care. So they might not like the idea that they will have to then look at people a little bit more closely for this particular subject matter. So, I mean, it's not something that we need to worry about today, but it's something that we may have to kind of
We will, and they need to know
about.
that it's coming. They're gonna have to deal with it eventually. Anyway, these patients are using cannabis.
I don't disagree with you, I'm just saying.
Yeah, it's inevitable.
Yeah,
We'll
that conversation will have to happen.
So I just have a question about that. So I agree on a couple of points. One, I really don't think specific medical conditions and statutes is a good idea. I think it's much better to be following standard of care, et cetera. So I would agree with having that more open. When it comes to who can recommend cannabis, which section of that, or on which page is that? I'm sorry, I'm a little... Okay, so PA, nurse practitioner, naturopathic, is that right, DO? There's two PAs. Oh, a DO?
DOPA.
Right. Oh, because right now it is MD and DO, and that's, okay, thank you, because that's pretty much my understanding of the groups of people who are allowed to prescribe opiates.
Except for, with the exception of NDs, correct? With the exception of NDs.
Naturopaths can prescribe opiates. I think so. I'm pretty sure.
Naturopath told me they could, but
they don't
change.
We'll check. We'll check. And I think, and I'll just say that I don't think the naturopathic physicians like to, because there are a lot of other ways to address pain. So I'm not disputing that, but my understanding is that they are able. So we include naturopathic physicians on a lot of our opioid prescribing. So that makes sense to me, especially since the #1 condition that people are getting a medical card for is pain. And so just thinking about the regulation of other controlled substances that people are being prescribed for pain, that makes sense. So it's not necessarily every provider, it's the providers. Anyway, we should just double check so that we're being relatively consistent across this.
I'd like to touch on the conditions list for a second. The only time a condition has been added is at the hand of the legislature. And one of the conditions that we added was pervasive and degenerative neurological conditions. And the reason we did that was it covers a lot of things. It covers lupus, and fibromyalgia, and spectral disorders, and things of that nature, ALS, those things. And part of the reason we did that was to allow a patient to get cannabis to treat a condition, not a symptom of the condition. So now, rather than getting a card for the pain from fibromyalgia, they can actually get a card to treat cannabis, treat fibromyalgia. They don't need to get a card for the pain. But the doctors, the prescribers, these clinics haven't made that switch yet. And I know early on when that first started happening, there were a couple of doctors that were interested in how do we do this? Can we just list fibromyalgia? And I think that ended up coming further up the chain in OHA, and I don't know how it got resolved, but part of what happened with getting rid of the conditions was, and allowing a doctor to sign a note, authorize you cannabis for whatever condition you both agree on. That's what caused the craziness in California and Washington. There was no control over it. You walked around with a doctor's permit that, you know, a letter from a doctor that said you could use it for the hangman or for the bicycle accident that you're suffering.
For anxiety. California, you qualify on anxiety.
Anxiety.
Sort of,
so,
but yeah, everybody has it.
You know,
Everybody has a card.
there's a trade-off in having that list, and I think we need to really seriously consider, you know, not serious, but have a deeper conversation about whether we retain that.
Well, the presumption is based in training, right? So we mandate that providers who are authorizing the use of cannabis have been trained, and therefore we're establishing a standard of care. And based on that standard of care, they should have the autonomy to decide to authorize that access to cannabis with that patient. Again, that's
Oh,
based in the
absolutely.
training,
Yeah.
so when doesn't, that has to proceed.
Right, absolutely, and I agree with that and I support that. But I'm just saying, when I tried to get the list removed a couple of sessions ago, that was the outcry that we heard. We can't just have these doctors signing for patients to get cannabis for hair loss. That's what we ran into, you know.
Well,
So
yeah,
it's unfortunate, I think
unfortunately,
the time has been.
that's inaccurate too. I mean, we allow physicians to write blood pressure medications for, you know, blood pressure issues.
Right,
And
no,
we
I
don't
understand.
control that, right?
Right.
So if science has determined that cannabis can be used for everything, then a doctor presumably could put every single patient on cannabis. There's nothing wrong with that. But there has to be a good validating reason, right? And so just to slap doctors' hands for over authorizing for cannabis is silly. It's what are they authorizing for, on what basis, what conversations do they have with that patient, how is that patient using it, is it making a difference? Are they getting off their prescription drugs? I mean, there's a lot that goes into that conversation.
Right,
But the best of me is bringing to this commission a concept for training so that we standardize care, right? So that we're protecting both providers and patients. We're respecting the integrity of cannabis as a medicine. We're honoring the research. We're really creating a silo through which research can improve, right? We haven't gotten into the subcommittee report on research, but we have observational opportunities at our hands through this training program, right? So training the clinician in a certain way, tracking outcomes, prescription reductions, opioid overdose reduction, et cetera. I mean, that's a test case that the Research Institute could benefit from. So we really are developing a nice, robust ecosystem. And I do think it hinges on training that clinician in a standardized way.
Yeah, I support the proposal to remove the list. And just a proposal to, Esther had a concern with the overly broad proposed replacement language here. I wonder if it could be changed to any condition the AP reasonably believes can be mitigated with cannabis, or insert some legal term of art there that will, imply the necessary reasonable protections that.
Based in standard of care with the legal terminology that I think we're all comfortable with. It's pretty standard.
So just a couple of points. One is that, in fact, we do have guidelines for clinicians when recommending cannabis use. And so the guidelines are not specific to condition, but they do offer a standard of care around do an evaluation, do an in-person physical, track, make sure that the condition is benefiting, etc. So basic standards. So I think we should at least reference that in here as well, because that does talk about standard of care, and that is a document and a public process that we went through to get that. I agree with you about the standard of care. There is, in other types of medicine, we have kind of the standard, because you've done clinical trials, et cetera, and so you have basically on-label use and then off-label use, and so we don't really have that here. There are a couple of, again, research, national documents, and National Academies of Science put together a thing about what the conditions and what could benefit from, et cetera. So I don't know that we need to go to that. I agree with training, and I agree with something around standard of care, because standard of care, I don't know exactly how to do it, but I would like that to be based in, evidence-based medicine or some studies that have been done or some trials, again, without listing the conditions. And so to develop the standard of care does need to have a scientific basis, as well as following, again, the guidelines for recommendation, which is look at what the side effects, look at all the other potentially, conditions that the patient might have that could be exacerbated by this and made worse. It's basic kind of medicine that you actually evaluate. You test for whether it's had the positive effects, you look for side effects, you reevaluate, etc. I can't remember everything we put in our standards, but I like to think they're pretty basic and that they were pretty good, and I think it's really important for us to follow those.
Yeah, the clinician working group, it was referenced in, I think it's referenced in here, actually. But yeah, I mean, that was based in standard of care. But clinical cannabis medicine is no different than standard medical care. It's just a different product, okay? And I think with the exception of your first visit having to be in person, which again, we do telemedicine for a lot of things. I think consulting and authorizing the use of cannabis could actually work through telemedicine that first visit. I'm in 100% agreement with that, and that would be the foundation upon which we base training, right? The standard of clinical care, it's no different. But just to bring your attention, if you guys missed it, we did address sort of the structure of the training program, at least with a broad list of topics that it would cover, starting with plant science, so taxonomy and botany, the endocannabinoid system, its function and dysfunction, pharmacology, toxicology, substance abuse and addiction, contraindications of use. So yes, clinicians will be trained when not to recommend. And then, cultivation, processing, and distribution. Clinicians need to know what the patients know, and they need to know about the points of contact that they're engaging with outside of the office. So again, this list is not exhaustive, but we thought they were the broadest elements of what would create a nice and robust and rewarding training program.
I really appreciate the thought into that, the educational component. I think this will bring Oregon up with some other states that have medical programs that do require CME or some sort of education as a requirement.
And you guys, and this will sort of tease out all the bad players, at least from the clinician perspective. I know that's been a concern, and I know there was an age when growers would bring in extra patients into that doctor who would just write the authorization, and I get it. But I do think that this is a framework that will really clean up some of the issues surrounding the healthcare providers at this point.
And I do think that's one pass we need to make, especially for all of you familiar with all the various products of all the task forces and committees that have gone before, to cite those documents and draw from them as much as possible in our final version. We'll just make this feel robust, not just like a bunch of new ideas, but really building off the hard work that people have done before. So I think that's just a pass through the final report we need to make. All right, should we move on to patient access subcommittee?
Excuse me, ma'am. I need to change my batteries. So can you hold on for a second?
Stretch break for a few seconds, and then we'll move on to patient access.
All right, report on subcommittee on patient access to the Oregon Cannabis Commission. I'm not going to read through all of this, but I will point out that creating a comprehensive patient access program, especially a program outside of the grower-patient relationship, is no easy task. It is a larger challenge that can be realistically accomplished in a single session of the legislature. Doesn't mean we shouldn't continue to move forward. We want to provide the legislature with a solid roadmap towards expanding patient access. It's going to be a multifaceted approach that needs to be everyone's participation. I mean, patient access means patients have access to and can afford what they need, and the one size does not fit all. What does not fit all, and it does not mean that what a patient needs is available 150 or 200 miles down the road. We have to deal with local access even where there aren't dispensaries. So this is an important part of expanding that. And we have to get these licensees to participate. And I know that OLCC doesn't want to deal with patients, and I can certainly appreciate that, but we do have ways within the OLCC system where we can actually expand patient access with some help. There's some structural things in place that could actually give us pretty quick access if we can pull it together. Other thing is I would like to say is that on all this stuff about how much patients can take, how much they can have, what all the possession and diversion criteria look like, some of this stuff can be handled by the Oregon Liquor Control Commission. That's why Compassionate Oregon advocated for consolidating tracking. Just makes sense to put all the information into one bucket you can all take a look at with certain confidentiality requirements. But we don't support OLCC's involvement in determining what patients can take, what they can have in their possession, how that all works. And I think through the education and training of the providers, that will minimize. But that's the Cannabis Commission's job. That's why we set it up. That is the intent of the legislature, to deal with issues facing patient access and to have a forum to discuss that and work through some of these. And again, as I said earlier, we've got hundreds of medical marijuana growers that, in spite of all the stuff they've been through over the last 4 or 5 years, are still willing to produce for cannabis, for patients. And if we don't set the bar for our patient access program at least that high, it's a huge disservice to the patients, to our committees, to our commission. And one of the things that, you know, tightening all this up does is it forces patients into unregulated markets or into retail stores that they can't afford. Or worse yet, it sends them back to the medications they've worked so hard to get away from. So, in our subcommittee, we've talked about several things. The first being patient eligibility and how we figure out how to do that. The general consensus around that at this point is a combination of indicating on the cards of patients that have got a reduced card fee. That would be a quick and simple way to take care of about half of the patients. They're just designated, it goes on their card, they get a little, you know, following their number, whatever it might be. And in combination with federal poverty guidelines. Now, poverty guidelines are a little trickier, but we qualify other people in assistance programs in this manner, so it shouldn't be that much of a lift to just shift it over. There are a lot of people that are out there that are indigent, homeless, whatever it might be, that for whatever reason they can't get into the program, and we need to make you know, allowances for those folks too. But that gets us even deeper because, as we say under this patient eligibility, that some of these homeless and indigent people meeting social programs aiding members of the homeless and poor have restrictions regarding medical cannabis in light of legalization and restrictive policies. Regardless of presence of medicine and limited refuge, these people can't get these services if they have a medical marijuana card. So we've got to address that. Another important thing about patients is the ownership of the plants by the ownership of the medicine by the patients. We've got to address that. It's probably outlived its usefulness, but I'm not willing to toss it aside necessarily until we have something that will work better. And possession limits also still may remain an issue. You know, this whole 24-ounce allowance is nuanced. It's hard to understand. It's hard to explain. You know, what do you mean a patient can have 1.5 pounds of weed at any time or at all times? You know, these sorts of things we do have to work through and figure out. And back to Dr. Knox's subcommittee, these are things that will be addressed as we work through how providers recommend for patients. So if a provider, for instance, recommends to a patient, well, really all you need to do is pick up, you know, a jar of gummies and eat one 3 times a day. Those people won't be such an issue, but the people that are getting free cannabis from their growers, that makes it a little trickier. Okay, so to that point, maintaining the grower-patient relationship. This is an important relationship that provides many of our patients with products they will not often find in the adult use marketplace. Many of these more fragile strains, they're not profitable, so the stores aren't going to carry them. But the ability, so we got to maintain that relationship at least until we get into something that's going to provide better. And this relationship is really important because it allows the patients to have access to a person that will work with them, that will develop a product that alleviates or mitigates their symptoms. So, also important. How to use the OLCC adult use system to facilitate greater patient access. Always troubling for the patient community. They don't trust OLCC very much. in their ability to adequately and appropriately address what patients get. But nonetheless, there are things in their system like the bump up program and the ability for stores to dispense free and low cost cannabis that certainly should be looked at as an avenue to get product to patients, especially in the short term. What can the patient and grower community do to help facilitate a supplemental patient program? Again, we've talked about this a little bit, but the patient community has to start changing how they think about using cannabis. You know, again, smoking whenever or wherever you want to, or whatever it is you might think you might want to be able to do, just because that's what you've been doing for the last 5, 10, 20 years, doesn't necessarily mean it'll fit in the new new model. So we're going to have to evaluate that. And again, this is a springboard for us to our next meeting for the concept. We flesh this out, work on refine some of this stuff. Access for patients in residential care facilities, hospitals, and medical facilities in general. This is a tricky one, but some of the residential care facilities are beginning to sit up and take notice, especially when it comes to neuropathic pain, nausea suppression, and appetite enhancement. One of our committee members, Clifford Spencer, has been actively working this program like no other person in the state. I mean, there are some people that make sure they're taking care of their patients and they go to their house and they'll check on them and that sort of thing. But this person visits his patients a couple of times a month, every one of them, and makes sure what they're using is working for them, or if it needs to be modified or whatever, and he takes it back and he deals with that. So, you know, the other thing is there's a lot of us boomers that have been smoking weed for a long time, and we really do want to take our medicine into the assisted living facilities with us. We want to be able to take our capsules or our suppositories that we've been using and mitigating our conditions with to the hospital with us and check them in with med nurse so that they get distributed, you know, given to us with our other medications. So, you know, if you're taking a blood pressure and a blood thinner or whatever it might be, and it comes around for the morning medication, you get your capsule of cannabis as well. So, funding. Big issue for all of us. You know, we're writing a program that's, you know, barely keeping its head above water. And it makes it hard to imagine that there would be any money left over for anybody else. And when we had our first subcommittee meeting, Dr. Chu asked us if we had $300,000, what would we do with it? And then she said, well, if you had $3 million, what would you do to enhance patient access? Well, we may not even get a chance to have $3 million. So a couple of things have come up that we've talked about. Increase patients and reduce staffing. I don't see that happening. Not in the immediate future, not in a program saving surge in patients kind of way. I just don't see it happening. There's too many roadblocks. It's too financially burdensome for patients and their growers. I mean, if you've got a patient that's growing for if you've got a grower that's growing for 8 patients, that's already costing him $1,600 in growth site registration fees. Now he has to jump in metric, another $500 for user fees, all that sort of stuff, and it just gets overwhelming. Somebody that's growing for 8 patients right now is probably spending upwards of $4,000 to meet all the fees that are required to provide for those patients. So the other thing we've been talking about is amending the retail sales tax allocation scheme to entirely fund the program. But then you would have to take into consideration how much, if any of that money, would also be allowed for research and enhancing patient access. So, you know, one other thing that I didn't put on here that came up briefly in our last conversation was a fee on inventory for the growers and the processors to help support the patient access, supplemental patient access program. We're still kind of muddling through that, but you know, it never fails to grab the attention that there's 1 million pounds in inventory and there's this and there's that. So that's where the cannabis is, and if we can figure out some way to put a fee on inventory, some kind of sliding scale to help support our program, and then anything that would also help reduce patient fees and grower costs. And then any money that is received, any revenue that's generated by fees dedicated to research. So it's not all the answers here in these 5 or 6 little pages. And as I say right from the start, it's a big project. And so what we like to do is focus on, like Dr. Knox did, on some specific amendments to ORS 475, and then continue to work on longer range strategic issues that will make sure that the program survives and that we continue to serve patients.
Just a comment on lowering patient fees, Anthony. I do foresee the elimination of cardinals through training clinicians. I think that's just going to happen naturally because people are going to be able to write authorizations within the context of a patient visit for the condition. We're not going to see patients going to what's an essential cardinal now and having to see a doctor who is willing to step into that role. So I do think we're going to see the elimination of those fees, which
doctor paid, doctor visit fee.
For an OM&P doctor visit fee, and I think providers are charging anywhere from $120 to maybe $175 in Oregon for that.
Yeah, anywhere from $100 to $175.
Yeah, and so that's in addition to the fees to
the card. So
yeah, so if that right there could reduce half of the fee burden for patients.
Well, any patient that does not receive a discounted fee card pays $200 for a card. They're going to pay $150 for a patient. And then if they're growing someplace that they don't live, that's another $200 growth site registration fee. So just for me, before I started getting my veterans discount, it cost me $550 every year to renew my card. Acceptable. And we've reached the point where you can't increase the fees anymore to save the program because people are walking away because the fees are too high now. So, you know, we just redirected funding for the OHA programs that were being funded by fee revenues, and I think it's time to make that switch for the program in general. And I know we've spent a lot of time figuring out, you know, that fee structure and who gets what, but I think that uppermost in that revenue allocation needs to be cannabis program.
Thanks, Anthony. I know I'm late to the game here, so I've missed out on a lot of policy conversations. But speaking as an OLCC licensee, I'm very much in support of dipping into cannabis taxes and OLCC funding to support low-income patients. Excuse me. And also, we desperately need a system which allows OLCC licensees to donate products and medicine to patients. You know, that we've heard a million times about the £1 million in inventory. Prices are lower than ever. There's a lot of farms that are going out of business. There's a lot of farmers that can't sell the product no matter what they price it at. It's an excellent time to develop a system which allows you know, farmers and processors and retailers to support low-income patients.
Yeah, because most of these growers, you know, some of these larger growers, they got 300, 400, 500, 600 pounds of product still sitting on their shelves. And there will come a point where they will destroy more cannabis than they would have had to donate. And that's what we're trying to avoid here. Because, I mean, burning cannabis for the birds is for the birds. You know, we want to, as we expand this patient base, the amount of marijuana available for diversion shrinks. You know, when you're required to give 75% of your product away to patients, that is going to shrink the overall supply, and those are things we need to start focusing on.
Yes. So one point of clarification. OLCC licensees can currently donate to patients. It's a little bit funky because of the way that the statute is written. A grower cannot do it directly. It needs to be routed through a retailer. But that's 100% possible today with no changes to law. And people just simply aren't doing it in any large numbers. Also, according to our data out of Metric, approximately 15% of the sales that retailers are making are to OMMP cardholders. So we do see that a large percentage of cardholders are using OLCC to access their medicine. Well,
I don't know about large percentage, but yes, I get your point, absolutely.
So that exists. You know, I take exception to the remarks that OLCC doesn't want to deal with patients. I think we have tried to accommodate patients through our system. What we don't want to do, and I think what Anthony would agree that we should not do, is tell people how much they should be consuming. That's where the agency has gotten really uncomfortable, and it's come out in our rulemaking when we're looking at things like the bump up canopy, and we're trying to balance patient needs with, you know, agency interest in mitigating diversion, and it's left us with results that really kind of nobody likes.
And that aren't being taken advantage of because of that.
And the final comment I have about access to medicine, which is just a general comment, it's not about my agency or about cannabis, but you know, how are low-income residents of Oregon getting access to other types of medicine?
Co-pays.
And you know, is that are there any mechanisms there that we can build upon? You know, if it works for other stuff, maybe it doesn't work for cannabis because of the federal prohibitions, but maybe there are some models there that we can borrow from.
Yeah, absolutely.
So let's just regroup a moment because we only have 15 minutes left and we need a period of public comment. So I think I'm going to have to cut short the presentations from the other two subcommittees and maybe we can just read, you know. But I think, so it's July, we need to wrap this up, I guess shortly after our next full group meeting. So, and I think as other subcommittees, research probably isn't, but other subcommittees are continuing to meet in the interim, right, to refine their legislative concepts, or are you guys kind of wrapping things up? Okay. Well, I would just say, I think, at some point, all of these need to be in one unified document. I think it's probably time to move to that and try to make the format uniform across. So can I work with the OMB staff to do that?
You said that Jeff had a format for that.
It did, and I forwarded it to you.
I think that would be really helpful to start from, and then kind of everybody's got their concepts, and then we can start putting them together.
That sounds great. And we may need, I think like in Anthony's report, and everyone just may need, you know, we can sort of shoehorn it in for now, and then we may need just a little more discussion to figure out what are we actually recommending in very concrete terms, and what are the priorities this year versus let's mention it, maybe we'll put it on the back burner as more of like our long-term strategic stuff or something for another year. Maybe more information and some of the surveys that we're doing. So we can work on that in the interim and then circulate at least 2 weeks in advance of the next meeting with the expectation that everybody will download, read, and come with it fairly well marked up. I think the only agenda item we'll have really is just getting that report to a final version. Does that sound okay? We'll just like squeak under the deadline as much. The other thing I wanted to bring up, the last thing is just I promised myself that we would just take a vote on yay or nay for listening tour this fall, because I think we need to decide now if we're going to schedule that before weather gets too bad for everybody to hit the road. Does it feel like something we want to do this fall? Do we want to bump it to next spring? Can I just get a quick read on that? Because I think there's just a lot of organizational and next spring.
Depends on the focus. For me, it depends on the focus of the tour. When we talked about it earlier, there was some discussion about going to marijuana grow sites, and I've been to a bunch of those. I don't think that's really what we need to be looking at. I think it'd be service better to go to a hospice facility where there's residents using cannabis. Hey, find out what that looks like. So just
Oh, I see. I guess I was thinking of it as a way for us to communicate what it is that we're doing on the commission and then get feedback about that to sort of shape our next year's agenda. But I could, you know, we could do it this fall, we could do it this spring, I think that would still be time.
I would say the spring for personal reasons, because I'll be on maternity leave.
What's the due date again?
October.
So my only comment about the spring is legislative session starts in February, and I don't know how active, and my guess is that depending on what we come up with our own report. So, so just keep that in the back of your mind. I at least here, and I have lots of other things on my plate, but legislative session is always an extremely busy time for those of us working in state agencies, and I know it's been very busy when it comes to the Joint Committee and, you know, other cannabis-related statutes.
They're not advocating for programs, are they?
I'm sorry?
We're answering questions.
That's right. We're answering a lot of questions. A lot.
Hey, this is Pat. I was hoping this agenda item had something to do with having these meetings in alternate sites. When I first spoke with Andre and a couple others about this, I understood these meetings would be spread around Portland, Salem, Eugene, Bend, and I feel a lot of guilt every time that I don't make it to Portland. So is that still on the table?
Yeah, that's totally fair. Yeah, absolutely. I think that is also a purpose of some of these. We call them listening to, but it could also just be we have a regular commission meeting at a different site, you know, and then we get a different public crowd there, or have a separate event at the same time, so that we can really open up the time for public comment and have questions about us and who we are. I like that. Did you have a feeling about timing then? Yeah. Maybe sooner, since we haven't seen you, sooner rather than later. We're not interested in seeing you in spring, so we'll just...
Yeah, I mean, the only real problem I have, since I'm a doc who still sees patients, we try to get our clinic schedule 90 days out in advance. So whatever we would schedule, I would like it to be beyond 90 days, and then I could block my patient schedule, that sort of thing.
Yeah, I'm kind of too.
It's never hard for us to just drive to Eugene.
So true. That's so true.
So maybe that's just our November, is it November meeting? We're meeting every month. So
Every 2 months.
Yeah,
So
we could do November.
oh, I thought September was already. Oh, I guess yeah, we could do November. September's already scheduled.
Scheduled, I don't know, I mean, for us, it would just be finding the venue if Dr. Lickey has it already blocked.
Oh, I don't have my thing, sorry. Yeah, so if he already has it blocked, so that's within his 90-day window for the September, we could research and see if we could find a venue. And maybe near the library.
Well, I was going to say, or maybe Pat, does the health department have a room? Doesn't have to be huge.
Yeah, I'm curious. I was thinking the same thing. We have a conference room we use a lot for public health meetings for CLO, the Conference of Local Health Officials, others. But how many attendees are in that room with you now? How big does it need to be?
180.
So we have commission members, staff, and I think 10 maybe or so public comment folks. Again, if there may be more, since we haven't done it in Eugene, we may have more who come. But yeah, no,
Yeah, we're like rock stars here.
there are not 180 people. More like 25 maybe. I'm not counting.
I got 15.
20
Total.
You counted 15? All right.
We could accommodate that pretty easily. If you want it to be at the health department, you know, it's a free building. It's centrally located downtown Eugene on 7th Avenue.
You said the magic word, you said free.
What about the Steelhead Brewery?
It's walkable from the health department.
Oh, good.
So Patrick, this is Carol. I'll connect with you to get the name so that we can do some research on that. So possibly we hold the September meeting in Eugene, and then maybe we look at maybe Bend in the spring, or you know, something to try to get around, and then Southern Oregon as another area, because I think we definitely need to do Southern Oregon. I just wouldn't want to do it probably after November.
Why don't we just fly?
All right.
Use the OHA plane.
All right, so I apologize for the time crunch, but we have a few minutes left for public comment. Let's just everybody restrict their comments to a minute or two, just so we can approximate finishing on time. So I don't have a sign-in sheet. Mike, do you mind? Thank you.
But actually, Sunny's on. Rights to speak. All right, Sunny Sanchez up first. Sorry.
Testing. Okay. Am I recording? Okay. For the record, my name is Sunny Sanchez. I'm a grower in Lynn County and a resident of Benton County, Corvallis, Oregon to be exact. I would just like to make public comment on the waste disposal protocols. I think that those could be improved. My suggestion to the commissioners is to define when a marijuana product is unsuitable for sale to the public, aka also known as a pull date. I also think that it would be beneficial for the OLCC to provide deposit centers for expired products. That way they can take it in and destroy it. And it also keeps licensees accountable. And one of the things that we're focused on here is minimizing or marginalizing diversion. So that's my comment on that. So my second comment goes to what I heard from the Patient Access Committee on social programs in particular. It is my opinion that restrictive policies are the backbone of a successful alcohol and drug rehabilitation program. And a lot of substance abuse issues happen at the level of homelessness. And also there are, it's a key part of diversion in the courts to send people to alcohol and drug rehabilitation. And also we have a large population of people suffering or dealing with mental health issues. So that is my comment on that about social programs. So when forming your recommendation for the ledge, I would suggest maybe modifying the homeless shelters and diversion programs or alcohol and drug rehabilitation centers to exclude if it's even on the table, you know. So just want to keep that straight and see as many people come into recovery as possible. Also, one of my big things is HB 2198 and the restriction to, if the 20-pound transfer should ever happen, there's a restriction where growers in CTS that actually qualify to transfer can only transfer to a wholesaler or processor. I would like to start the conversation of an expansion to retail, and that would need to be a policy change at the legislature. So that's all. I'll conclude and pass it on to the next person with public comment. Thank you.
Thank you. And next up, Mike Rockland.
Testing. Mike Rothman here. Cannabis nurse.
One minute, buddy.
I need 10 more seconds because of what Anthony just said. And also a member of the training committee. And I want to say a couple things. Awesome meetings, very well. Trying to keep a schedule on this subject of the last 4 years is difficult at best, so thank you. Good leadership here, great committee members. And one comment on, I think that Oregon Cannabis Commission ought to be the centralizer for the mission. I mean, you know, look what we've done, look where we're headed, pulling it all together and not even being a state agency at low cost. That's awesome to me, so keep it going. That's what I say. That should be a recommendation. And then centralizing, you know, we've got people with OLCC, OHA here, so law enforcement, we've got the whole gamut, so that's really good. I don't see OGA here. I know they got invited to one meeting, but you know, this is a plant we're talking about, and that's what concerns me the most, is agricultural, horticultural issues. ODA has access to research, although that's been a little bit questionable. And they've also got field people well-trained in inspections of field crops and things like that. So they're a major participant, I think, that's missing in action. And that's the other issue, is the hemp. Even though it's separately regulated, there's no reason why this can't be brought together through this commission. I think that's the best way to do it, and then get the conversation back to legislature. One comment on the integrity issues is that proficiency testing was mentioned. I think it's actually a requirement. That's not only necessary but important. Also, I've asked about metal testing, which other states do, and I think we can do that at a reasonable cost, so we need to explore that. It's really a research question. How much contaminants are out there? We don't know because we're not testing for it. Other states do have that data, so that's a concern. And finally, I'm really happy to hear people are in support of some issues we've raised with more providers. I mean, that's just in mainstream medicine. More providers, diverse providers provide more access for patients. And like Dr. Rachel said, I think you will see diversion go down as well as costs when we have more providers, more mainstream. I've seen that some of the data showing more individual, and I've talked to doctors in the general mainstream, they are willing to sign an authorization if the patient comes to them. They're in a little bit of quandary, but I think it's a lot different than it was even 5 years ago. And it's bound to get a lot better. Lots happened in 5 years here in this state and around the world. So thank you very much.
Thank you. Next up we have Leah Graham.
Thank you very much. Rhea Graham from Albany, Oregon. I'm a longtime patient and cannabis business owner. I would like to first thank the Commission for your time, for volunteering and being here. We need this program to get back to the basics of medicine for patients. We need to repeal these horrible laws that have gone into place. It's ridiculous. Let's get away from worrying about if people have too much cannabis at their home. How much alcohol can I have? Seriously. The OLCC is greedy and focused only on gaining control of cannabis and hemp. They are so proud of the dollars given to cities and counties. What they fail to mention is the cost to society of those tax dollars. How many people died from alcohol-fueled accidents during that month? How many people were physically and/or sexually abused that month by someone who had been drinking? Also, we could get these tax dollars. Woo-hoo. Patients have been robbed by this state for too many years. Millions and millions of dollars have been taken from OMMP patients and given to other OHA programs. Think about this. These other programs have been supported by the sick and dying. The state should be ashamed of their actions. The OLCC cannot keep children and minors out of alcohol. In fact, they literally allow candy to be sold right next to alcohol in a store. I'll send you pictures if you like. I have photos, okay? They're not fit to regulate any part of the medical cannabis program. We want to keep our cottage industry and not give it to big business and not give it to OLCC. There's no such thing as a marijuana plant, okay? You can't find it in any botanical book. It's a cannabis plant. Let's use that word. As to the prescribing of cannabis, the form currently says this is not a prescription for cannabis on the APS that every doctor signs. Remember, you cannot die from an overdose of cannabis. Why are we so wrapped up in this, how strong it can be? You can't die, so what's the big deal? Let's use this Cannabis Commission to the patient's benefit, not to the state's. Let it be the ground floor for building this regulatory committee. If we have to regulate it, let's be part of that, not give it away, right? What other farmer has to give away 75% of his product, Anthony? None. Okay? There's a federal medical marijuana program, so this federal prohibition is just crap. All right? Thank you so much for your time. I have many other questions. If I could have like 1 more minute, okay. Why is Sun-Grown going to be required to call and say when they're going to be harvesting when the indoor people don't have to, and the inspector has to be there while they harvest? That's absurd, okay? Alcohol kills by overdose. Why are we not counting hops and grapes? Okay? Why is the OHA willing to pay for pills that kill people? Okay? But they won't pay for smokeless cannabis remedies. What the hell? All cannabis use is medicinal. You're feeding your endocannabinoid system every time you use it. Okay? Perhaps a prison system can be given to the OLCC. Let's let them have that. Okay? The two deal with the same people more often than not. I think it's a great fit. Thank you. And another problem, patient growers that don't have a 21-year-old in their home are forced to use their medical cannabis recreationally if they want to recreate with it. Why is that? Thank you so much for your time.
Thank you.